Hello, good afternoon, everyone. Thank you for joining us today. We're so excited to talk to you about finding deeper resources, health, and housing partnerships, create new funding mechanisms for supportive housing. And my name is Liz Buck. I am part of our HRSA team at CSH. CSH is a national nonprofit. At CSH, it's our mission to advance housing solutions that deliver 3 powerful outcomes: improve the lives of vulnerable people, maximize public resources, and build strong, healthy communities across the country. CSH is a technical assistance provider for HUD and for also Health Service Resource Administration, HRSA, under the Department of Health and Human Services. Great. And so, our HRSA Technical Assistance Programs not only includes this webinar series on health and housing partnerships, but we also work on direct technical assistance to health centers and setting up regional trainings and peer-to-peer learning with one of our deep partners who's going to be on the call today, the National Healthcare for the Homeless Council. Our specific target is to build partnerships that can address the needs of those in our communities with limited access to primary and other health services and who are frequent utilizers and users of emergency and crisis care systems. So these are our panelists today. We're really thrilled to bring you these varying perspectives and folks working in the field. So again, my name is Liz Buck. I'm a program manager at CSH, and I'm going to be framing part of our conversation today. Lauren Berner at the National Healthcare for the Homeless Council will be speaking and moderating our facilitated discussion with our panelists. Jenny Eismert, who is the Vice President of Housing at United Healthcare, and that in and of itself, that title is really exciting. And so she'll be speaking about her role and how she thinks housing is really crucial in the healthcare field. And then we'll also be joined by Dewey Wooden, the Director of Behavioral Health at Orange Blossom Family Health Center in Orlando, Florida, where he'll talk about a really innovative program that's happening in a collaboration between many different funding partners and partners in general. They are a federally qualified health center, but they are working with hospitals, they're working with foundations and the community at large. So, as I described, we're going to talk a lot about kind of the varying perspectives of folks who are participating in this work and who are investing in supportive housing for vulnerable populations. I will frame the conversation. We'll hear perspectives from managed care, FQHCs, hospitals, and community, and why they're really invested in this work. Lauren will guide a facilitated discussion with our panelists, and then there'll be time for audience question and answer. So I encourage folks to write in your questions in the chat function, and we will be helping to give those to our panelists to answer, and so we'll have time for that as well. And so I love this slide as a precursor. So we'll get right into the slides and right into the graphs here. So this is coming from a really revolutionary book called The Healthcare Paradox. It came out about a couple of years ago. And you'll notice the United States is drawn here along with several other countries. And we'll often talk and you'll often hear folks say, we spend more on health care and get pretty mediocre health outcomes compared to other countries. And a lot of health economists have been scratching their heads and trying to figure out why that's the case. And this really makes a powerful argument. So this looks at expenditures percentage of GDP. The black bar at the bottom looks at the total healthcare expenditures. So that includes sort of your hospitalizations, emergency room visits, and admissions. And so what we think of as really strictly healthcare. The light bar at the top is the total social service expenditures. So that really includes our supportive housing. And so when we actually look at what these total, we'll notice a few things. One, we'll notice that we are out of whack compared to countries globally. And we'll also notice that if you think of these two sort of investments together, we're actually sort of in the middle of our investment. And so a powerful argument has really been, and the health sector is really seeing, that investment in social services is really crucial to delivering overall positive health outcomes, and that there's sometimes a misinvestment of funding here in the U.S. And so we often talk about who are these high users of healthcare. This is a JAMA report that uses Dartmouth Atlas study research and really drills into who are the high-cost Medicaid recipients and users. In this, it's pretty startling. So 5% of Medicaid recipients account for nearly 50% of overall spending. And when you think of it, a really small percentage of individuals are accounting for a large percentage of the cost. Drilling that down even further in a lot of research that has been coming out in nearly the last couple of years, we're really finding that a significant percentage of these high health users have significant challenges in terms of social determinants of health. And so one of those huge challenges is homelessness. And so, recent health affairs study has shown that nearly 30% of individuals in an integrated health system in Denver who are their high users of health care are homeless. And we're really finding that across the country. And so this really, this argument about really needing to bend the cost curve in healthcare is really going back into those social issues and really causing all of us, both in health and housing, to realize that ensuring that we're housing folks effectively will reduce these healthcare costs, and that this is really crucial. And so I think the good news for a lot of the housing folks in the room is that there's been a widespread empirical evidence that supportive housing is a health intervention. And so we've really seen across the years in studies throughout the country that access to safe, affordable, permanent housing has improved outcomes for vulnerable tenants. We know that reduction of ED emissions is really significant and is a real cost driver for many healthcare stakeholders. So this is something that hospitals and managed care are really interested, and they're really interested in avoiding readmissions. The reduction of Medicaid costs overall, including as you've seen here, is really in the interest of the public at large, and Medicaid directors across the country are really interested in this. And we know that there are many quality of life improvements as well, including the reduction of substance use disorder. But we're also really interested in continuing this body of knowledge and ensuring that we can understand the specific health outcome metrics that our managed care organizations and our federally qualified health centers and hospitals are judged on, like medication reconciliation, lower blood pressure, et cetera, to really continue to further this evidence. But we know throughout this body of literature that this is really, in some ways, the most effective pill you can give to many folks who cross these crisis systems. And so this is the signing of the Affordable Care Act. A lot of folks look happy in that picture. This slide is really to talk a bit about the healthcare policy changes and changes that have sort of been happening over the past 10 years and how this has really impacted our work in terms of housing. And so the first major issue is access. And so we know that there's been increasing access for individuals for health care because of the Affordable Care Act. Many, and we know because the Supreme Court decision enabled states to expand Medicaid or not expand Medicaid. So we know for many of our folks now getting access, and many of our clients are now getting access to healthcare, which is an incredible shift. We also know that, even if states haven't expanded Medicaid, there are, the ACA created and expanded opportunities to incentivize, to give states flexibility under certain Medicaid waivers to pay for services like supportive housing. So we know, Louisiana and Texas, under their specific waivers, have covered individuals through supportive housing benefits, and so increasing both access for folks who have expanded Medicaid, but also providing incentives for states who haven't, and that's really significant. Another major significant change has been, and this has been, created and expanded through the ACA, but also was sort of happening prior to the ACA, is really this idea of paying for value. And so, this has been a seismic shift in healthcare. So previously, folks who had been readmitted to the hospitals, again and again and again, maybe some of our tenants or folks that are homeless, there was not necessarily the incentive to keep folks out of the hospital, right? Because there was a fee-for-service model. So the more folks that went to the hospital, in some ways, the better revenue that hospitals had. What's been happening across the country is that healthcare is now moving towards a quality-based or value-based system, whereas hospitals are now being incentivized to keep people out of the hospital. So now Medicare changes have been created that ensures that hospitals and obviously managed care are being incentivized to ensure that people aren't being readmitted to the hospital. And so this shift has really put the focus into social determinants of health and really recognizing that there are a whole slew of factors, and a crucial one is housing, that are part of the reason of why people are continue to be readmitted to the hospital. Great, and so this is what we call, and healthcare folks know this on the line, and housing folks have probably heard this too. So this is what we call the triple aim in healthcare. And, the ACA was meant to address sort of all of these issues. So this means in reducing healthcare costs when possible, improving quality, and improving access. And really, those are the goals of many of the healthcare stakeholders on the line. Where it becomes challenging, of course, is that there are numerous sort of health stakeholders, and the healthcare delivery system is complicated, and often requires the collaboration not just of complicated healthcare stakeholders, but also a complex housing delivery system as well. So just as a little bit of background, and a lot of panelists are going to get a little bit into the nitty-gritty of this, but to describe, state and federal Medicaid agree on services and target populations for many support housing services. And each state, under different waivers may have different target populations and data and specific priorities. And oftentimes states, and this requires an agreement between both the CMS and so the federal CMS, and also from the state Medicaid office. And so in some ways there are a lot of different opportunities depending on states. Hospitals vary across the state. So some hospitals can be nonprofit, some are private, and state incentives vary based on whether they're in expansion states or non-expansion states. So you'll hear from Dewey on the line, who's working in Florida, who will describe a little bit about the incentives in his non-expansion state and how hospitals have really stepped up to the plate there. Federally qualified health centers have to meet specific health metrics, so they are required to meet certain federal metrics, but oftentimes these don't always align with, MCO metrics, managed care metrics, or other hospital metrics. And so they're working in preventative health. And so when we talk about improved quality and reduced costs, in some ways, if we're doing our job right, we really want folks to be going to that preventative care. And so that doesn't necessarily mean reduced costs there. And then managed care has, they're working across the country, and Jenny from United Healthcare will speak to that. But the incentives and an ability to collaborate often varies by states and different regulatory frameworks, and it often varies based on if states have integrated medical and physical health, and behavioral health, and where the incentives are there and carved out versus integration, and Jenny will describe a little bit about that. So I think at this time, now that I kind of set the stage, I will give it to Jenny to describe a little bit about their work and her job and role and how they see housing as really crucial to health.
Housing for including us in this, what we think is a very important discussion around social determinants of health. I am the Vice President of Housing for United Healthcare, and through my role, I am very acutely focused on driving innovation and program performance, specifically around how it is as an organization that we are looking at the connectivity between housing and healthcare. I think for a lot of the reasons that Liz has very beautifully teed up with the changing policy environment, with the implementation of the ACA, and then also, too, as we're seeing our state partners that are looking at an ever-increasing healthcare budget for their public medical assistance programs, that are really looking beyond just kind of traditional healthcare as a means to an end for trying to drive value in the system. And also, like Liz has already talked about, is that influencing factor of the social determinants of health that really impact Medicaid populations that are extremely low income based on their eligibility in and of itself for Medicaid. So, really quick, United Healthcare Community and State, which is the segment within the United Health Group businesses that I work for, is focused on insurance solutions for low-income, underinsured, and medically vulnerable populations. We currently have Medicaid managed care contracts in 25 states and Washington, D.C. And through those Medicaid managed care contracts, I thought it would be important to just very quickly set the stage on what exactly that means, because we almost have a responsibility in working with both our state regulatory partners and then also with the federal government as well. Because the federal government really drives, I would say, the best way to think about it is the framework for Medicaid, and then state governments through how it is that they are designing their Medicaid programs. Really what you're going to see, the tagline in the Medicaid space is, you've seen one Medicaid program, you've seen one Medicaid program, and that really is speaks to Liz's comments around the variability in how states have structured their Medicaid programs, and how those programs are structured really drives how it is as a Medicaid managed care company that we are able to administer Medicaid managed care programs, and through that incentive structure, how it is that we are incentivized as health insurers to target around specific quality activity for the populations that we serve. serve. So currently we do traditional Medicaid managed care, which is the TANF populations, moms and kids. We also administer Medicaid managed care long-term services and supports waiver programs, which are the programs that are targeted to medically complex populations like individuals with intellectual developmental disabilities, the frail and elder, and any other type of kind of micro subpopulation that the state would like to target to offer some additional Medicaid benefits to. So why is it, one question we were asked as we were preparing for this discussion is why is it as a Medicaid managed care company are we interested in exploring and getting more actively engaged with socioeconomic factors that we know that influence the populations that we serve. And through our work and through the introduction of the ACA, the expansion of Medicaid, and largely the offering of insurance now to single adults that were historically not insured, we're realizing and ensuring new populations now that that are greatly influenced to some extent by the social determinants, and how much those factors are really influencing how an individual is making decisions, not only about how it is that they access health care, but how it is that they are dealing with day-to-day situations about nutrition, paying utilities, keeping successfully housed. All of those factors really take priority over an individual's willingness, for example, to engage in preventative treatment, maybe get a flu shot. So as an organization, we really see addressing and getting more engaged in the social determinants as a key factor for us in being able to more holistically create solutions for the individuals that we serve. And through my role, specifically heading up the housing initiative, I'm really interested in my work in exploring the connectivity between housing and healthcare. And I'm not going to spend a lot of time on this right now. I think Liz did a really great job of exploring that connectivity. And I think it's largely well understood what that connectivity means for individuals when they don't have a house, and getting into the more complex of individuals that might be housing insecure, the homeless populations that are typically the chronically homeless are also typically experiencing acute medical and behavioral health conditions that's really contributing to the housing insecurity issues that we're seeing. And that translates into, high cost, high utilization on how they're accessing the system. This, I think, is really interesting. It is a study that came out from Enterprise in partnership with CORE, actually just within the last 30 to 60 days. Not necessarily different per se in understanding that housing does, in fact, impact healthcare costs. I think what's revolutionary about what they did is that they started to analyze the Medicaid claims data to really take a look at, to examine key healthcare outcomes for people who moved into 3 common types of affordable housing: family housing, permanent supportive housing, or housing for seniors and people with disabilities. And through looking at the claims experience, they've really established a cost story, I think, that directly ties back to Medicaid claims experience that really does demonstrate the value and how it is, the value that housing provides to the total cost of care expenditure. And I think it's a great study for those in the seminar that haven't looked at it. I would encourage everyone to take a look at it, because it's evidence that's tied back to Medicaid that I think has not existed previously, that demonstrates the value with housing for certain populations. So housing and Medicaid. So predominantly as a Medicaid managed care company, I think Liz touched on this, there's differences in Medicaid program design, and those differences really can dictate the interest and opportunities to innovate in health and housing collaborations. States are going to be in a variety of stages about how it is that they're looking to reform their system, whether or not they have populations in Medicaid managed care or sitting in fee-for-service. Fee-for-service tends to be a little bit more difficult. Those are typically programs that do not have incentives driven through the system to try to push the system towards a value-based system. Medicaid benefit integration that Liz had spoke about, we see a lot of states that have historically carved out behavioral health services from the physical health services, which really creates challenges when, for example, as a Medicaid managed care company, we might be the Medicaid managed care contractor for the physical health benefits, but the behavioral health benefits might sit with another payer, or they might also sit in fee-for-service. So those create challenges really in our ability to effectively and efficiently integrate services around the individual and to provide integrated behavioral and physical health services that we know are foundational to, especially for more complex populations, is foundational to developing a system that supports recovery. And then coverage for housing-related support services. I would say, you know, there is a tremendous amount of momentum with states to explore covering those services. It is few and far between, and they are typically covered through waiver programs that are targeted at the very complex populations. So CMS did recently issue guidance that is encouraging states to explore coverage of those services. So we're optimistic. And we're also hoping that states are continuing to explore more aggressively how it is that they can innovate programs around connecting housing and health care. And then certainly, you know, states have to consider policy and practice options for maximizing that Medicaid funding structure. I think that that's highly important when we're talking about supportive housing, in the fact that as a Medicaid managed care company, the state really dictates to us what services that are considered covered under the state benefit plan, and so we, to some extent, are limited to offering coverage for those services, recognizing that there are still gaps in the services that are needed for individuals, for example, that might be in permanent supportive housing. So through our work, and I'm going to spend a little bit of time here, and I'm trying to be sensitive to time structures as well to get us back on track, but we're, as an organization, we're looking at, very actively looking for opportunities to partner. And through the work that we've done in certain markets, we're really starting to collaborate, desiring to collaborate with Continuum of Cares, the supportive housing providers, and then obviously as a health plan, we think that there are strengths that we can bring to the table that when all three of us collaborate together can really build supportive programs that to some extent, you know, try to reduce system fragmentation. I think healthcare in and of itself is complex. When you layer onto that supportive housing providers, the affordable housing system, you know, it's adding complexity to complexity, as Liz already alluded to. So while these collaborations are great, you know, I would say we're early in our work here, and they, you know, being kind of at the forefront of those collaborations, I think that we're obviously kind of in a growing pains period, but we've learned a tremendous amount and feel very strongly that this is the direction that we want to go. So coordinating access and targeting those most in need with the COCs, coordinating and leveraging funders of supportive housing, and then connecting health plans and housing providers really is what we are encouraged in our discussions with the COCs. Obviously, with the supportive housing providers, you know, there's a tremendous amount of opportunities to leverage the strengths of the supportive housing providers in being experts at treating complex chronically homeless populations, for example. And there is a tremendous amount of opportunity for us to leverage that expertise in A, locating our members, and B, understanding when there might be a change in condition, where there might be a need to access resources that are available under the Medicaid state plan that can really work in concert with the supportive housing providers to provide holistic support to the individuals that I think we're both collectively trying to see be successful in where it is that they're residing. So recognizing the need, I think United, through this work, I've somewhat already discussed this, but, you know, newly eligible populations with Medicaid expansion states, I think to some extent we are waking up, especially to the homeless population, because these have historically been populations that have not been covered in Medicaid. And so I think that we are at a very important recalibration of the system that is really recognizing that these are individuals that are now covered under Medicaid. Housing support providers now are really at a time of opportunity to seek Medicaid funding to some extent for the supportive services that they're providing, and then really seeing an opportunity for us to collaborate across both healthcare and the supportive housing providers. In our work, you know, some of our perspectives in evaluating those opportunities, we really think that they're endless. I think it's helpful to understand the limitations that the structure of the Medicaid program has for Medicaid managed care organizations. But with that, you know, we're really seeking assistance from experts in understanding where our members are, the opportunity to improve quality. I think recognizing the expertise for treating this population is key, and improving quality, I think, is central to this work, and that the downstream impact of that, we believe, and I think has been largely been proven, is the improving of utilization, because for us as an organization, it's really about the right care at the right time and in the right place. And somebody accessing the emergency room frequently or being admitted inpatient more because of a housing issue, less about a clinical issue, you know, those are things that we really value as an organization, is ensuring individuals are getting the right care at the right time and in the right setting. And I would say through what we've learned from our supportive housing providers is really, you know, we think that there is a mutual benefit from collaboration. We also firmly believe, although it can be difficult, but we've worked through it with some supportive housing providers, is that information can be shared in a protected and safe way. And then I think collaboration, you know, certainly for us and for our partners, has really been a win-win for us in supporting these individuals. So I'm going to stop there and pass the presentation over to Dewey, who's going to talk about his work in Florida.
Thank you, Jenny. Hopefully everyone can hear me.
We can hear you.
Great. I think Lauren is going to run the slides for me. And I'll just discuss kind of what our project is here in Orlando, Florida, in Central Florida region. We do business as Healthcare Center for the Homeless. We're at 330H from HRSA, Community Health Center for medically underserved area and population. We're an FQHC, as I said. We serve about 15,000 patients here in the Central Florida area, which comprises Orange, Osceola, and Seminole counties. For those of you that are familiar with the recent primary, we would be known as kind of right in the middle of the I-4 corridor here in Central Florida. About half of those clients at any given time are a homeless or indigent population. We do service those with Medicaid and insurance as well. As you see from the slide, about 160 employees at this point with about a $10 million budget. We have medical, dental, behavioral health, pharmacy, psychiatric, vision. We have medical mobile units that go out into the Tri-County area, both dental and medical. We've got about 6 satellite sites in the Tri-County area, and we provide integrated behavior. We follow an integrated behavioral health model. So all of our behavioral health is integrated with our clinical and medical care. We are a non-expansion state here. We don't have the waivers that they do in Texas and in Louisiana. Our governor kind of didn't go that route, and our legislature hasn't approved the additional expansion down here. So we're kind of exploring ways to utilize Medicaid for targeted case management to be more sustainable with our project that I'm going to talk about in a second here. Our community started with this a few years ago. There was a point where both our mayors, our county and city mayors and the local region realized that we had been listed as one of the worst areas of homelessness in mid-sized metropolitan areas. There were a couple of coincidental instances. We had some fairly visible community members, homeless clients that were visible downtown that had passed away while waiting housing on the streets based on our limited housing options here. The media attention, of course, on those cases. And out of that was born the Central Florida Commission on Homelessness, which is the board has many, many different funders and stakeholders on there from many of the largest organizations here in Central Florida, the Orlando Magic, our Orlando City soccer team, Walt Disney World, Universal Studios, some of the large hoteliers. Both the mayors sit on that board, and they decided that they're going to address the homelessness in Central Florida in terms of going towards more housing, and they committed to a study on how that was impacting us financially here in Central Florida. Of that study, what they found with our basic cost of living index here in Central Florida, that the per average person's annual cost was about $30,000, which jives with many of the other communities in the land, an average of maybe $30,000 to $50,000. I've heard even up to $70,000 in certain communities across the land. And with our at the time most recent PIT counts, point in time counts of our chronically individual homeless, you see the dollars there times about 1,500. Chronically homeless individuals, those are chronically homeless and verified for a year in the community of homeless, at about $50,000 a year to keep them homeless on the streets in our Tri-County area, which of course involves those type of costs that many of you are familiar with, the cost of multiple incarcerations on public nuisance charges, things like that, multiple frequent utilization of hospital ERs and other associated costs that add up, and rotating into shelters, transitional housing, things like that. So that's where you see that number for our local community's expense. So the response came down from both the mayor's office, our county mayor, and our city mayor, Buddy Dyer, that there was going to be a commitment. Both this actually started with the 25 Cities Initiative to End Veterans Homelessness last year, or by the end of last year. And out of that was born the Permanent Supportive Housing Initiative by both mayors here and the regional commission that we have here. And so the city of Orlando put up $1 million to house a project to house 300 chronically homeless persons in 3 years, utilizing, and out of the research they did with going to other Housing First programs that had begun in other regions, in Houston, Salt Lake City in particular, New Orleans, Chicago, to model after that, utilizing Housing First here. And so they put out the offer to match, and one of the largest matching funds was the largest hospital network in Florida, actually, which is Florida Hospital Network, matched with about $6 million over the next 3 years to provide the supportive and wraparound services, which is what we were tasked with. We were kind of chosen based on our integrated health work, our already established network of outreach workers that were already out there in the field engaging the homeless folks, both discharging from the hospital, discharging from the jails, and also collaborating with local police and parks and recs and things like that to locate homeless folks and get them into integrated health care. So because we already had that network, we were well positioned to answer the call to implement the Housing First philosophy here in Central Florida. And again, along with that, those private funds, we also engaged, again, with a lot of the board member connections and the funders that collaborated to provide additional matching funds for various things that I'll talk about farther down in the slides. As far as many of you are familiar with the Housing First, with our project 100, we were tasked within the first year of trying to house 100 people using the Housing First philosophy, which is a low case management ratio. there's an ACT model that many of you are familiar with, an assertive community model, and an intensive case manager model. We kind of went with a blend of that, of having particular team members, for instance, a particular psychiatric nurse practitioner and a particular ARNP nurse practitioner that would work with our team of outreach and case management to determine disability and HUD eligibility, and also to help with mental health treatment and such with our particular clients. We keep the case management ratio low. We're capped out at about 1 to 17, so that keeps the engagement very involved. They don't feel overwhelmed. They're able to give the time and quality care needed for some of the folks that are suffering from the most acute serious mental illness and substance abuse issues as we house them in Housing First. Along with Housing First, we also utilize the harm reduction model. We don't require, this is a low barrier model. Again, we use little bit to minimal barriers to getting them housed. Again, we follow that philosophy of someone needs a home, the first thing to do is let's get them into housing first, and then we'll worry about things. Obviously, we do set some certain boundaries with working with clients, but we meet them where they are. We don't use sobriety as a barrier or a requirement to get into housing. We try to work with their legal background, felonies, and things like that to get them into housing. And then from there, we find that we're able to start the work of getting them involved with clinical services. And also we see an improvement in that, and I'll talk a little bit about that a little later. With our local continuum of care that we work very closely hand in hand with, who manages the coordinated entry system here in Central Florida, they manage a homeless registry. And you might wonder, well, how do we prioritize all of these homeless folks? Who goes first? Who decides? The region decided to use the VI-SPDAT, the Vulnerability Index that many of you might be aware of, which is about a 6-page assessment that rates people on a scale of 0 to 20. And based on the high score of that, they are prioritized onto a list. But we also, as a continuum, came up with other prioritization needs. For instance, if a client is in vulnerability of dying on the streets through an acute medical illness or domestic violence, victim of human trafficking, along those natures, we can kind of move them around on that list. But primarily, we're using the VI-SPDAT to prioritize folks on that list when they're referred into the coordinated entry system on the homeless registry. Once they're referred out to our case managers. They work with the local COC's housing location to utilize their inventory. They search out inventory and scattered site housing in the Tri-County area. We don't just tell people where they're housed. That's part of their preferences. They let us know where they'd like to be housed. We have source specialists and peer specialists that help with the warm handoff of getting clients into their housing, and also linked up with clinical care as well. The hospitals were, again, Florida Hospital was one of the largest buy-ins because of the frequent utilization that they were seeing from their chronically homeless population. One of the hospitals, which Florida Hospital gave us their first list. We consequently have another list from Orlando Regional, which is the second largest hospital system here that we're partnering with. On the Florida Hospital list, their top 100 of utilizers in the 2014 to 2015 year, in 14 months, those top 100 utilizers incurred $14 million in ER visits, just those 100 folks. As you see there, the number one person on the list was almost $1 million. That person, the number two person was about $650,000. So we were targeting those frequent utilizers of folks to try to get them into housing, and I'm proud to say that those number one and number two folks are currently in housing. One was a veteran as well, and we're already seeing a reduction in those ER visits due to them becoming permanently housed, and that's kind of one of the goals. We started this, the preliminary talks about 1.5 years ago, and once we were chosen with the city and our grant funding, we decided, well, how are we going to start this project? How do we learn from this? So proud to say we're partnering with CSH, providing the technical assistance to both the city and the region down here. We attended their last summit to gain those resources and contacts and get more familiar with the Housing First principles that other communities were using. We did do site visits to Houston and Salt Lake City to see how they're implementing Housing First over there. and some of the other trainings and workshops provided by CSH. We collaborated with our local continuum of care to build and refine the CES system, utilizing the VI-SPID app prioritization and implementing Housing First along those lines. And I have to say, for us, you know, not every agency might be ready to follow the Housing First philosophy. And that's fine. In our continuum of care, there were plenty of agencies that decided they weren't going to get on that bus, that they were going to use abstinence-based sobriety for entry into their housing program. They were only going to take certain types of populations, things of that nature. And there certainly are, you know, we're not going to judge that. There certainly is room, there's always going to be room in communities for shelters and room for different types of interventions as far as housing and treatment. But, you know, our community decided to move forward with this, and many of the other agencies are beginning to come on board, given a lot of the difficulty with the HUD funding coming down that might be changing from transitional to more permanent housing that HUD's on board with as well. We hired at full capacity. We've got a manager of outreach and case management, 6 case managers that keeps it to a 1-to-17 ratio, a housing specialist that coordinates with the housing location services to help folks lease up their own place. They sign their own lease. 2 peer support specialists that have histories of adversity themselves that are able to kind of present peer-supported solutions and help with transitioning into housing for folks that have been homeless for, you know, some of these folks have been homeless for 20 years on the streets. Program specialist that helps with the logistics, and a disability specialist as well. With our next slide, it fits together. We work closely with our local COC, which is supported and helped directed by the Regional Commission. We work closely with the registry meetings, which happen on a weekly basis, where we're going down the staffing list of all the locally homeless in the Tri-County area on a weekly basis in that CES system. We utilize, many of the communities probably online use the Homeless Management Information System, or HMIS, for their data entry. That's what we use down here, and HSN, the Homeless Services Network, who's our continuum of care facilitator, manages that HMIS system, so the data is in there for all the local agencies to see as far as the last touches of where those clients are utilizing shelters, other agencies, housing, and clinical services in the Tri-County area. We provide all those case management and wraparound services that are referred back to us for housing. We do aid in housing location. Again, this is a scattered site program, so we are looking at one of the challenges that I'll talk about later for some project-based housing, but for the most part, we utilize scattered site apartments, 2-1s, and houses that are identified that work with us. And a lot of those housing options are incentivized, which is some other matching funds from the city that put up incentivizing funds for apartments and complexes to work with us and work with our particularly specific population that might have issues with felony backgrounds and things like that. And also all the clinical services, one of our outcomes that I'll discuss is because of our clinical services, we're able to provide integrated care right off the bat with any of the clients that we take in terms of all of their clinical and mental health needs and substance abuse needs. We're able to provide all of that for them. So it is truly integrated for us. The data that we utilize, obviously we use the HMIS data on the current homeless populations. This would be the next slide, sorry. Click to this. All of our HMIS data on all the existing clients that are already entered into HMIS in terms of their touches for HUD eligibility, their episodes of homelessness, and other demographic information that we sometimes need, ID, and housing preferences and things like that. Also, our local PIT counts, our veteran surge counts, that all helps with our HUD eligibility. Again, the 2 hospital systems provided us with all of their FUSE data, and we continue to collaborate very closely with them so that we're targeting that. And we have quite a few, sometimes we joke about the lists that we do have. We have quite a few lists from many of the interested stakeholders. We have a list from our downtown police department in the city of Orlando, our downtown visibility list. We also have a list from the 2 counties as well. And of course, everyone wants to see folks in their communities that are on these high visibility lists. And so we try to cross-reference those lists to prioritize those clients. But A lot of what we're doing is tracking those clients that we see on those hospital lists so that we can track the data at the end of the project periods to see the savings of costs, obviously, to the frequent users. And we can correlate that to the cost of initially input into the system and the project versus what costs were incurred if folks are just left to their own devices, homeless and recurring through the ER visits that they see. As far as our outcome data, we're tasked within the first year, those 100 clients, we want to see 85% of those program participants remain housed for at least 1 year. 80% of those will maintain or increase their income in some way. 80% are documented reduction in hospitalizations, and 80% in reduced incarcerations. I'd like to say just very briefly, we started this, we received our grant in June of last year. We started housing people the end of September. We're right about at the 6-month mark of our Project 100. We've housed 58 people to date, and I'm proud to say that all of them continue to remain housed. They've all maintained or increased their income. We've seen at least probably a 90% reduction in hospitalizations. And we had our first one gentleman who was arrested this week. So we have one person who did get arrested post-house up. In addition to that, we decided to track on our own because of our clinical resources that we're tracking those clients that are diagnosed with a couple of chronic illnesses, chronic mild to moderate hypertension, diabetes. We're tracking outcomes of those folks that are housed. We'd like to see how housing impacts or improves their health, which we're seeing that, and that data is being collated. And we're also administering PHQ-9s, which is a self-reported depression screening, to all of our clients to see if there's a reduction in depression with our clients as well. And we'll be reporting on that data as we continue to go along. And that's kind of what we're doing here in Orlando.
Great. Thank you so much, Dewey. Hi, everyone. I'm Lauren Berner. I'm with the National Healthcare for the Homeless Council, and I'm going to help facilitate our conversation with Jenny and Dewey. We are running a little bit over on time, so we're going to try to go through this pretty quickly. We may run over with the Q&A session, but if you have questions, please ask them in the chat box at the bottom. We will be doing a Q&A document for any questions that we don't get to. So just jumping right in. First, we're going to talk about data. So Jenny, I was just wondering if you could talk about how you are working with communities to define the target population.
Yeah, I think our work is right now pretty early on in how it is that we're doing that. We're going at it from two different angles as it relates to what I would broadly describe as a housing insecure population. We are looking at targeting for probably on the most chronic side where most of the interest is from just a system expenditure perspective is on the chronically homeless. What's difficult for us as a Medicaid managed care company is our ability to identify those individuals accurately with the data that we have. So right now, part of what we're doing is twofold. We've been successful with partnering with some of the supportive housing providers to actually data match our membership with HMIS, and it's an effective way for us to basically utilize the HMIS data to confirm who in our membership is actively seeking those services. The other thing that we're doing is taking a look at what we already have in-house. So with the rollout of the ICD-10 data, the ICD-10 coding, the great thing about that new coding methodology is that there are more coding factors for the social determinants of health, including homelessness. So what we're seeing is an uptick, mostly with safety net providers, that are coding individuals as they're presenting for services as being homeless. And we found that to be a really accurate indicator, for example. So, and We also have a clinical program that's focused on community health workers, targeting our top 2% of our healthcare utilizers. We've largely been doing that just on healthcare spend alone. We're now starting to look at, you know, who within that kind of isolated population that's our top 2% is also being coded as having some type of social determinant influencing factor. So those are some of the methodologies that we've looked at in targeting the more chronic populations. For the less chronic populations, I think that work has been a little bit more challenging just because as the availability of the kind of softer social determinant data points for, you know, maybe our population that sits at, you know, maybe they're the top 15 to 10% of our utilizers. We see those really as, you know, potentially being the feeder system into these more complex populations. So we haven't been as successful in targeting in that realm, but are actively working in that space to see if there's opportunities for us to more effectively target.
Okay, great, thank you so much. Dewey, Orlando is using multiple data sets. I think you mentioned some of this earlier. But how are you making meaning of all the data that you have, and why is it useful to have all of these different data sets? I know you have access to some of the hospital top users and police top users. So.
You mean in terms of how we utilize that or how we obtain it?
Both, if you have time.
So we reached out to certain different collaborating agencies in terms of government, like I said, with the local police departments, the corrections department, and other folks like that, who actually, once you reach out to them and we started the process of talking about this project, they were pretty eager to share data with us. And the great thing about having one large hospital system work with us, that enabled us to leverage the other hospital system, basically, who said, hey, wow, you have a certain list over there. We've got a list, too. And once that happened, we didn't even really have to reach out to them. They reached out to us. But having those data sets helped us, you know, target and collate those lists and cross-reference them to find the highest utilized. Because usually the folks that are going to the ER are the folks that are getting arrested pretty frequently on the streets for public nuisance laws and things like that. And a lot of the incarceration stuff is public record to begin with anyway. And so 9 times out of 10, we're going to see that data on there. Obviously, with all the stakeholders, many of the different stakeholders want to see different data and want to see their lists attacked. And so we're getting pretty proficient at creating different types of dashboards for everybody because they all have their own little ask. And so collating those dashboards sometimes with that can be difficult. I do know that with HMIS, and I saw someone had asked about HIPAA and HMIS, that affords us a great ability to pull data out of there, different reports about who's getting housed, who's getting referred, what status they're in, and pulling the data long-term over different periods of time so that we can give those data sets to frequent utilizers lists as well and collaborate with the hospitals. As far as HIPAA concerned, everyone that participates in the HMIS, all agencies and all individual users in HMIS sign ROIs, release of information, and so all that information stays within HMIS.
And I think there too, Liz, you know, I would like to chime in on the HIPAA, on the privacy issues as from a Medicaid managed care perspective. I think that you know, it's interesting to hear about the sharing of HMIS data up. We frequently are trying to chase down that data, and we oftentimes hear that, you know, while we can share information to you guys, we being the service providers want information from the Medicaid managed care organizations. And I think that sharing de-identified information, I think, is certainly achievable. But as with the privacy rules and how it is the regulatory structure that governs how we share PHI, really creates, I think, some big obstacles for us to more effectively share data from a Medicaid managed care organization down to a service provider. So those are some of the things that we have been working through, but it can be a challenge just based on the rules that govern the use of that data.
Definitely.
Great, thank you both. We had a question come in that I thought would probably tie into this slide, so I want to ask that now. Jenny, can you talk a little bit about the billing and payment mechanisms that United uses to pay for housing?
Yeah, absolutely. And I'll kind of talk about it from two ways. When I hear pay for housing, I think I'm interpreting that as paying for rent or maybe paying for a lease. So we're going at it kind of two ways. As a for-profit organization, we are actually investing capital through low-income housing tax credits to invest in the actual increase of portfolio of affordable housing options. It's something that we're choosing to do as an organization. As it relates to covering housing under Medicaid, there are very specific prohibitions against covering rent, for example, under the Medicaid benefit structure. Some states are experimenting with CMS to see if they can expand that coverage, but we are really limited as an organization to covering what I would probably quantify more as housing supportive services, such as, you know, locating an apartment, money follows the person is another really good example of it. We're really limited to our ability to cover those services as they're defined by the state underneath the Medicaid state health plan benefit structure. So if the state is defining those under the structure, then we certainly have a funding mechanism to then distribute funds for those services. But it really is defined at the state level on what it is that we can cover.
Great, thank you so much. And then Dewey, just a quick question here. Earlier you mentioned that once you got one hospital on board, another hospital decided that they wanted to be involved as well. How have other stakeholders gotten involved since this project started? And how have you been able to navigate some of those partnerships?
Great question. I'm trying to think off the top of my head many of the stakeholders. Sometimes it's based on, you know, we have a great collaborative relationship with our regional commission and the funders collaborative that goes along with the Central Florida Foundation that manages the private matched grant from our local hospital. And that funders collaborative, we're able to bring challenges to that funders collaborative, which is, that's just a huge, huge asset to our community because it has so many different prominent business and agency leaders there that have a network of their own, from the mayor's offices on down to former state reps and things like that. And actually the presiding judge of our local Ninth Circuit is on that board as well. So we're able to engage in many different ways when we see a challenge of, hey, you know, it's not easy to just go out and look for a name of a homeless person. We're able to work with public records, work with the judge's office and the incarcerated to get a mugshot list, for instance. We were, you know, having trouble getting apartment complex owners, property owners to work with us as far as building inventory for scattered site housing. We were able to go to the city to get some matching funds to incentivize that, both with incentivized funding to work with us, a couple $100 just to house one of our folks, to creating a damages fund so that if there are any damages incurred by our clients, they'll cover that cost. We have what we call, they also provided the city, along with some of the stakeholders with the city, provided some matching funds for a barrier buster fund. So anything that a client needs that might come up as a barrier to get them housed, maybe they have some arrears or debts, or they can't pay a security deposit, or to bridge house them because they're particularly vulnerable on the streets until their housing matchup comes along in a few weeks. We're able to utilize that fund to pay for everything that would overcome a barrier to getting that person housed and keeping them housed. Food kits, we were able to leverage the local hospital system, which is part of the Adventist system, with one of the board members on our commission and our funders collaborative who works closely with a faith-based committee. We're able to get a lot of the faith-based community, which is, those of you that have been to Salt Lake City know how important that collaboration can be, to get some of the faith-based organizations here to partner up to provide food kits. So every one of our clients that goes into housing receives 60 days worth of food with a move-in kit. And other collaborators have provided furniture move-in kits for our clients. So it's just kind of taking those challenges that you might have, and if you have that kind of a strong collaborative and a commission in your region to utilize those prominent leaders and business leaders and go to them. Usually they've got the contacts that when we make the ask, 9 times out of 10, there's a solution coming down the way, and that helps out quite a bit. And obviously, those build on each other. When you're able to get a solution from one place, you can leverage that with other folks, and usually folks kind of fall in line, or other agencies fall in line. So.
Okay, great. Thank you so much. We have time for one more question, and then we're going to do a quick Q&A and then end in about 4 minutes. I apologize that we ran over so late. So my last question is just, what discussions around sustainability have your programs had, and what have those looked like? And this is for both of you. Just anything pretty quick. Maybe Jenny, if you want to start.
Yeah, sure. So it's an important dialogue that we're having, I think, as an organization, as we are experimenting with the connectivity of housing and healthcare for the programs that we're piloting. The sustainability question is coming up because I think for us as an organization, while we can make investments in this particular space, it's equally as important for us to measure performance and then also leverage those understandings to advance the policy discussion at both the state and the federal level to explore the opportunities to adjust or encourage innovation through Medicaid program design that offers up a consistent funding stream for these vital services for a very vulnerable population. And we are also, experimenting with capital investment structures and service alignment that looks a little bit different than some of the traditional mechanisms. And within those discussions as well, it's equally as important for us to see that the debt can be serviced effectively and that programs and services have a more secure funding stream than the historical reliance on grant funding and other funding streams that can be temporary. But part of the work that we're doing right now is to establish that performance understanding to help advance those discussions.
And then one brief Q&A question, Jenny, that came in. How much does the definition of support services covered by Medicaid vary from state to state? We talked a little bit about that variation.
Yeah, I would say it can be very, very broad in their variation of how those services are defined. So, and I think too, in their use of managed care as well. So under the waiver program, states, that's really where states are isolating and covering some of these softer tenancy-based supports, housing supports, and then just general kind of hygienic maintenance that's available in the community. Those are really being isolated in waiver programs, and the states are really defining those benefits, and they're pretty wide in their definition of what they're including as those type of supportive services. Housing support services specifically, I would say there's fewer states that are defining those under the waiver programs, but the momentum is there. I think states really vary in kind of their traditional thinking on fee-for-service, and then you've got some really innovative states like New York, like California, Louisiana, that are really starting to think about the social determinants in a different way and seeing the value of defining those in their waiver structures.
Great, thanks so much. And I'd also say the new CMS Innovation Accelerator program is providing intense technical assistance with 8 different states to really help them determine how they can best leverage Medicaid funding to help with supportive services for target populations. So thank you so much. Thanks for your patience. We're sorry we ran over. We had such great questions. Just as a reminder, today's recording and slide deck will go to you as well as answers to your questions. So if they didn't get answered, we will answer all of them. We have an upcoming webinar happening May 2016, really focusing on health centers' opportunities to work with deinstitutionalized populations. And when you log out of today's event, there will be a pop-out window enabling you to create a survey to let you know how you found this to be useful. Thank you so much. We're so appreciative of all the panelists speaking. We really think there are some great opportunities working with managed care, working with hospitals to develop partnerships and investments in supportive housing. So thank you so much, and have a great day.
Thank you, everyone.